quickly. And Shelly and Edgar, thank you so much for making time for us today. And I'm going to let you take it from here.
Thank you, Ellen. Appreciate it. You sound very important on that.
Oh, yeah. Better than what I am. Thank you, Ellen.
So today we want to talk about some things that Ellen brought to the table when we first wanted to know what direction to take with you all during lunch today. These are some of the things that were presented to her as you wanted to learn more about. So this is how we kind of came to this presentation, but feel free to send questions in our chat. Ellen can stop us. We do like an interactive. We, are virtual today, but if there is anything you would like to know more about, please put it in there for us. Okay, so today our objectives, we're going to discuss family dynamics that may arise when beginning hospice care for the Alzheimer's diagnosis. We're going to identify 2 ways of how to help the family, which is many of you all, understand and accept the situation, and verbalize how hospice can be different when you have dementia. I adore Barbara Carnes. Edgar knows this well. I love to quote her, but this is one thing that I took from her book. And today in the presentation, a lot of things in her book are relevant to this presentation. So I wanted to include it. But she says, there's a normal, natural way of dying. The goal is to help people have a positive experience, so everyone involved will have a sacred memory to carry with them. You want to talk about that?
Alzheimer's disease is sometimes called the long goodbye. The last years of diagnosis are filled with watching a loved one gradually become less and less able to function in the world. And it's very hard to watch them lose this ability and to know that they're unable to do the things that we think living is all about: eating, being active, finding humor, interacting, remembering. Leaves us feeling frustrated and helpless. And Shelly and I have worked with so many Alzheimer's patients and their families, and I think this is the difficult. Personally, I have not had a loved one with Alzheimer's, but working with other families, seeing what they go through, trying to understand, and especially in the beginning stages when they're trying to rationalize why this person doesn't understand them, why they're forgetting things. It's almost like a denial system, I think, that many caregivers have at first. I've had good friends who've had their parents with Alzheimer's, and it was very difficult for them trying to understand that they're not capable of it. It's not something they're doing on their own, but they're not able to remember some things. It is part of the disease process.
Yeah, I think back to my grandmother with Alzheimer's. So every setback was a grief process. So it feels very draining and lengthy, like the long goodbye, because every decline, you grieve that, and the loss of being able to smile, going back to just the person itself as they sleep more, eat less, interact less and less with their family members. The anticipatory grief that we go through, it's heavy.
Yeah, very much. And sometimes the behavior changes completely. I've had patients that all of a sudden started cursing, and the children would say, we're going to talk about it in a few. We're going to be talking about this
behavior changes.
It's hard for the family to understand why they never cursed their whole life and been so dignified, and then they're doing this. It's very difficult.
Yeah, dementia is different than other chronic illnesses because the time frame is typically longer. So you're grieving you're in that sort of transition period a whole lot longer than you typically would. So caring for someone with dementia presents different challenges than caring for people with other healthcare issues. It doesn't follow the same timeline that signifies approaching death from disease or old age. And hospice is ordered when the physician determines that the prognosis is typically 6 months or less if the illness runs its normal course. So of course, we don't have a crystal ball. We don't know exactly how it's going to play out or what the path is going to look like, but in their best medical guess, so to speak, they feel like, we're probably looking at 6 months or less. That's when hospice is typically called in, and there'll be an order, and they'll come out and talk to the family more about what services they're going to be providing and just expectations of how they can best serve you, and your loved one.
And we'll go into the criteria a little further in the workshop for hospice, but you may hear a lot of people say, oh, they've been in hospice for 5 years or for 2 years, or I always say sometimes, hospice is still, the doctor has to feel 6 months or less, and then every 60 days you still have to get recertified.
Yeah, recertified.
But Alzheimer's is a very tricky disease because a doctor may feel that and the patient does not.
And then it is 2 years.
Yes, but they're still appropriate.
Right,
so
exactly.
It's not that hospice has changed. A lot of people are saying, oh, that the regs, they have not changed. It's still 6 months or less, but everybody's individual.
Yeah, right, exactly. This is taken from CMS, that the identification of specific structural functional impairments together with any relevant activity limitations should serve as the basis for palliative interventions and care planning. A lot of times they're looking at what we call comorbidities. So is there anything else going on that could impact their health or the disease progression, such as CHF, which is heart failure, COPD, that's related to our breathing. I'm not a nurse, but just learning from the experience. And then are there secondary conditions that we often see with this particular diagnosis, which are frequent infections, maybe some pressure ulcers, wounds, the body oftentimes takes longer to heal and that kind of thing.
And that's why you as a caregiver may hear at some point, if a nurse does talk to you or a doctor talks to you about, do you want to treat this? Because it's not going to get any better. And sometimes, I'm not a nurse either, but a lot of times it's the comorbidities that actually end up leading to the death of the patient, not actually the Alzheimer's, but there's a lot that goes in with this.
Or even the secondary conditions, an infection that arises and, so many things can happen. There's no sort of set in stone path. This is called the FAST scale, and a lot of times the nurses and the physicians are looking at this to kind of place a person where they, fit on the scale. And usually we're in the stage 7 when we're looking at hospice care, when to bring that team in. But just wanted you to know kind of what that looks like. And that would be loss of speech or locomotion, loss of consciousness. Your ability to speak gets reduced to those 1 to 5 words a day. And then it goes down to unintelligible vocabulary, non-ambulatory, unable to sit up, unable to smile, unable to hold head. So when I think of this, I think of Dr. Susan Nelson, who I had the privilege of working with for a long time. And her visual, because I need a visual when I wrap my brain around things, she would say, think of it like a 6-month-old baby, think of the clock turning backwards. And when we're looking at the last 6 months of life with Alzheimer's, it's probably in the same place like a 6-month-old baby. And when you think of a 6-month-old, they're still like tripoding, they can't really have the strength in their core to hold their trunk up. And that's why trunk control is lost. They're starting those smiles where they're meaningful. Mamas say, is that gas? But it's, or is it a smile, meaningful smile? So that's kind of like what you're looking at.
It's a good way to look at it. And it also helps you as a caregiver because I know a lot of people with good intentions say, oh, go to hospice. But if you still have an Alzheimer's patient who's still very functional, walking around, eating on their own, that's not really hospice appropriate. This is kind of a guide for you to look at. They do have to be at the last stages. Like Shelly said, that's a good analogy. Dr. Susan Nelson said.
Yeah, because there's awesome benefits, for hospice. You get a lot of help. And so, and we know that the benefit is increased when you try to get in as early as possible, but you have to be mindful of the regulations and the criteria and, just.
That's why I was trying to just give you a heads up in case somebody tells you they're not eligible yet. These are the correct criteria that they have to
they're looking at.
Supposed to meet if you follow the regulations.
Right. So just in case you haven't had experience yet with hospice, the philosophy, it focuses on caring, not curing. And in most cases, care is provided in the person's home. It can also be provided in any place that they deem their home, like long-term care facilities, nursing facilities. Also, hospice can be provided in freestanding hospice centers or within hospitals. So there's different levels of care within the hospice benefit of Medicare. And typically private insurance follow that, but it just depends on kind of what's offered in that policy plan. But when we think of hospice and we talk about the levels, we're relating it back to what Medicare sort of allows. But services are available to people regardless of any age, religion, race, illness, whatever demographic. There's no discrimination. It is covered under that Medicare benefit. It's covered under Medicaid and most private insurance plans. But again, you have to check your policy, HMOs and other managed care organizations.
Typically, you have a family member who's serving as a primary caregiver, but it doesn't have to be a family member. I've had friends who stepped in to take care of a patient. Some people don't have family that's close by, or somebody, sometimes it's a sitter that we're working with, but we always kind of inform the family, the primary person, of what's going on. Members of the hospice staff make regular visits. The hospice team determines the plan of care, like how frequent the nurse is going to go, how frequent the aide's going to go. We have a chaplain and a social worker that's also involved with the plan of care. And like Shelly said, regardless of religion, but I've had about 3 atheists in my practice, and all 3 of them asked for the chaplain before they died. But if they don't, that's fine too. We accept the chaplain's non-denominational, so we don't push religion, spiritual, but it is there for support. If you have it, the social worker makes their frequency based on what the family needs for support. And every care plan is very individualized according to the patient's needs.
Mm-hmm. Yeah, because what's best for you may not be best for your neighbor. Sure. You know, you have to tailor it to what is needed and what is useful and what is supportive.
We've had families say, don't, patients that are doing okay, they say, don't come but once a week, because they're doing things, but then when things get worse, you can always, every week you can change the plan of care. It doesn't matter. It's not locked in stone.
Whatever's going on. Yeah. Because then something may come up and you need to see. Right. Exactly. So
that's okay.
You just kind of take it day by day, take it as it comes, but your team is there to support you in this journey. And hospice is designed to support the caregiver, whoever that may be. Like you said, a friend, a neighbor, whoever is in that seat. And
even role. Paid caregivers, they get very
paid.
Attached. So a lot of times we're supporting them through this also.
Right, that's true. Yeah. Like we said, support for those caregivers is assessed throughout that period. The range of services provided will vary on each individual situation, but that team of hospice are available by phone 24 hours a day, 7 days a week. And that's a benefit too. Even if it's Christmas morning and there's something going on and you're worried about it, you have the ability to call and reach out and just talk with the nurse, and they can visit on Christmas.
That's right.
We've taken call many years where the social worker is on call and can go out and visit. No matter, it's 365. That's right. 24/7.
24/7 we go out.
During hurricanes and the flood. I remember the flood was challenging, but I had rubber boots in the back of my van.
Yeah, you did. And even during COVID, Shelly and I both were lucky to work at agencies that we still went to see the patients. Nobody ever refused to visit from us, so we continue to see them through.
Yeah. Or started out as virtual because, and then seeing a person's face on the screen is different than in person. We lose out on those nonverbal things that we show care and compassion a lot of times. And they're like, oh, just come in person. We miss you. And I
always tell the family that they're still in control. The patient is still in control if they're alert and oriented, and the family is that you can dictate how often you want us to come, and we also are not coming in to take over your house. I've had patients who were free to leave. You don't have to be homebound with hospice. So if they want to go visit somebody or take a trip, it's like, you let us know. If the nurse is scheduled or the social worker, anybody's scheduled on that day, tell us. We don't want to interrupt you from getting out if you have a good day. So it's not meant to keep you at home.
I'm glad you said that, because another physician we work a lot with, Dr. Mark Cantro, he would describe it as hospice, like healthcare, we're in the pilot seat of a plane. And then hospice takes that person, all of our life in the plane, the physician or the healthcare team is usually in the pilot seat, but the hospice team puts that person into the pilot's chair to direct their care of how they want it to look like, or who's coming, or how often, that kind of thing.
The frequent question I get a lot when I do info visits is the medications. And I don't fool with the medications, but I always tell them, talk to the nurse, because sometimes our medical director will say, you don't need to take this anymore. It's not helping. But then if you still choose to take it, you're still in control. You can do that. It's your choice. Because a lot of people are scared to make any changes, afraid it's just going to interrupt the care they've been given all this time.
And it's a lot at first.
Yes.
You know, it's hard to process. It's, you know, usually it depends on what's going on. If you're in the hospital, then you're dealing with that, you know, initial shock and all the frustration and the feelings that go with it, and probably not sleeping as well. So our decision and our judgment gets affected when we don't sleep, and it can be a whirlwind. So, but your team is there to help you. So like you mentioned earlier, behavioral disturbances sometimes happens.
Hostility, anger, aggression can occur with dementia towards the caregiver, which can really leave you very hurt. I've worked a lot with caregivers who were told things or done things from the patient that they're completely different. And no matter how strong you try to be, it can be very painful and hurtful. And that's where talk to your hospice staff, help, you know, talk to someone. Sometimes you just need to get it out. I always found I found in my career that a lot of times they kind of like signal the caregiver that, I don't know if they felt like them or there was a connection. I remember my grandmother was dying. She had 3 daughters, my mother and 2 other daughters. And she singled one out, was so mean to this, her daughter, my aunt. And I always felt like his aunt was very independent, like my grandmother was, drove, you know, was able to do things. And it was almost like she had cancer. And my grandmother was the sweetest thing. But just at that moment, she just took everything out of my aunt. And I remember my aunt breaking down crying in the kitchen one day. And it's almost like, it's hard not to take it personally.
It is. It is hard because it hurts, right? And, you know, as much as we know, we take things out on the people closest to us, you know, because we know that they love us regardless and they won't leave us.
Yeah.
So there's that piece to it. But try as much as you can to separate whatever the current behavior is going on that's related to the diagnosis, and separate that from the memory of your relationship and the good times, because you know, try to recognize it's not that person, it's the disease. But it is hard.
It's very hard. I know just when my mother was dying, we had 5 of us, and my dad was still living at the time too. And she started getting the cancer kind of went to her brain a little bit. She started getting a little upset with me giving her the medicine. And I remember one time I was giving her the medicine. She wouldn't open her mouth for my sister. So I got the medicine. I said, she used to say she was queen of the bed. I said, well, I'm king of the medicine. So you're going to take this medicine right now. But, you know, I was lucky because I kind of knew that wasn't her personality. But I didn't want her to do that to my other siblings who were not in the medical field and hadn't seen this, because they would have been crushed and have to live with this. So like Shelly said, it's hard to separate it, but you don't want to live with this after something happens to the person, feeling the guilt, because you're there, you're doing everything you can. It's not really that person's personality.
Right. Yeah, that burden. It's difficult enough to be a caregiver, but try not to hold on to that. So I always say every family has dynamics, including my own, you know, to kind of normalize it. It's different personalities, different people, different things happen. So, you know, it's just a wide range, you know, and there's nothing to be ashamed about. You know, when people bring this to me about explaining the dynamics, it's, you know, very non-judgmental. You know, just tell us what we need to know to take the best care of you and to support you through this. But some things that may come up, number of children or siblings. Say we get a lot of people that, never had children, and so their siblings are stepping up, and then you have different, sibling type things, personalities coming into play. Some relationships are more supportive and some are more estranged. Sometimes things happen and you just lose contact, or even the proximity. If you live out of state, there's all sorts of feelings about not being there. And then when you do arrive in town, you want to be able to get everything done and to be as present. And then maybe, your siblings who are there, close proximity, kind of feel not resentful, but it's like, well, I'm here all the time and you're coming out of state. And, like we all feel a certain way. We have this lens of our own perspective. And a lot of times it's just kind of hard to wrap our brains. I mean, I don't know. I can't read your mind. We don't know what the other person thinks. And our experiences sort of shape that, what we see and how we relate it,
Yeah, and I think what Shelly and I have done with our staff that we work with is also to make them understand this patient and family had a history before we came in.
Yes.
And I'll just give you one example that we took care of this lady. She had 9 children, and I was supervising the social work department at the time. The social worker came to me and said, this poor lady has 9 children and nobody's coming around but one granddaughter. She told me I could call her children. And I said, be careful, because that just didn't sound right to me. And she called the first child, and the child cursed her out and said, why are you calling me? She kicked me out the house when I was 15. She called the second one. It was a similar story. So, like I told her, are you going to call the third one? I mean, just because this woman, we need to care for this person. They're our patient. We have to show the love and support for them. But understand, they had a history before we stepped into their house. You can't blame people for not coming around. And Ellen may delete this and Shelly may kill me, but my statement is that if you're an SOB all your life, probably 95% of the time you're going to be an SOB, even when you're dying. It's not the movies. Sometimes things don't change. So many times it's hard for a caregiver to step up and come back into that environment where there's animosity. There's some old issues that probably will never be resolved for some people. We've seen some that have been resolved. It's been wonderful, but I've had child molesters. I've had domestic violence. It's very hard. These are real things that we deal with. The world is not hunky-dory and wonderful. There are issues that come to the plate. So we educate our staff about everybody has a history. You can't just walk in taking sides with one person.
Right.
You have to look at the whole picture.
Yeah. We all have a journey and we don't know. Like you said, there could have been abuse on the part of that person. Now your hospice team will care for them regardless, but it impacts the relationship that they have with their caregivers. And it's helpful to kind of know that strain and how it impacts.
Right.
Because, if the patient was abusive in the past for the caregiver, how that caregiver is feeling, processing this, there's an extra layer there. To delve into. And then also a lot is, if that person didn't have care plans or talk about it, not everybody is open to talking about end of life and their wishes. And so there's a lot of turmoil, am I doing the right thing? And just try to remember, what would they want? Would they want CPR and all of those resuscitative measures and artificial feedings, or would they want comfort focused treatment? And Barbara Carnes talks about, does the person want their last days to be filled with pressure and force? Like, I hear this a lot, they got to get out of bed, they got to eat, they got to do it. But when we're at ends of life in those last months, last weeks, we have to often shift.
Yeah.
And the shift is realizing they're probably past that point of
leave me alone. Let me sleep.
I understand it is important to get out of the bed and it helps our well-being, but at some point it's like more pressure, to feel that versus just letting them, kind of do what they want. And if that's being in bed, just
and I think that's where the staff comes in. Even, the social worker, the nurse will help the family understand that force feeding could be worse, because the body is shutting down or breaking down. You don't want to force food. That makes it more uncomfortable and more, some pain could be involved with that. So I think it's just a general understanding of when it is the body is breaking down rather than just the person's refusing to eat. There's just a lot of differences with that.
Yeah, Barbara Carnes goes into that more about always offer, but if you're at the point of trying to shove the spoon down,
it's too much. I always would tell people, because especially in Louisiana, people love to eat.
Yeah, it's our culture.
If Shelly, like, let's say you take care of Shelly and she's like hasn't eaten much in a couple of days, and she goes, I want some red beans and rice. Well, don't cook a big bowl. Bring her a little dish, because a big bowl sometimes intimidates right there and they shut down, don't want it.
Yeah.
But even if you got to bring that
even
bowl
it's a couple
again,
bites though,
it's good.
Because a lot of families say, oh, I made this red beans and rice and she only ate 2 bites, and I'm like, but that's good. She was satisfied. She got what she wanted, and that's enough.
It met what was meant.
Yeah. So how do we sort of help the family through this with that long goodbye, that continuous grief that we feel, that gradual progression? Grief begins with that initial diagnosis. I talk a lot about loss of future and helping the nurses kind of understand how that grief feels like. And recently I was talking to one of the nurses. I had someone, the family was really grieving loss of future plans, trips that weren't taken, and not, a grandchild on the way that this person probably won't see. And, all these things that we have in our head about what our plans are, and knowing that's not going to come to be. And there's grief in that. And the nurse was saying how, recently her daughter changed her major. She was going to be a nurse, and they had all these plans about working together as nurses. And then when she shifted, she realized she was grieving. And so that helped her kind of relate, maybe, because every situation is different. We don't know what that person is feeling. We're not in those shoes. We can't walk those shoes, but to kind of understand, like, oh, that's similar, that feeling.
The future, And like Shelly said, as a caregiver, you may have had some hopes and dreams of things you want to accomplish, especially with a spouse or even a parent or a friend. And then you realize that it's not going to happen more than likely. So it is a grief process. I always call it secondary losses. You're just losing that part of your future that you were hoping to have with this person.
Yeah, we grieve for each shared memory that we lose when that mind fades, first before the body does. We grieve each loss, that we're able to do, each experience. Then those interactions, those jokes, that no longer come. And the loved one gradually becomes the person we don't know. So oftentimes, the personality changes, and you may used to go out to eat and go to the movies, and now the dynamic's different because you can't do that anymore. So how do we spend our time? How do we connect? Because human connection is the basis of anything. And so when that is change, there's grief there too.
Great. And I in my career, I've had many couples where the children don't seem to understand how much that caregiver is doing, and how much their parent, who does have the Alzheimer's diagnosis, how much they can't do for themselves or can't do it. And I'm having to really work with that caregiver, the other spouse, to really either talk to the children or just give them support, because nobody seems to understand. They're with that person 24/7. And the children may pop in every now and then and see how things are going, but are not really around for the difficult parts. So
every family is different, different things, but we must adjust to the change, because the person with dementia can't process really what's happening. They can't, that executive functioning, they can't understand why that their personality change is affecting the dynamic of the relationship and how that other person is coping with that change. We have to learn in some way to accept that our loved one is not who they used to be, but who they are now. And this is part of grieving, living in the present, Memories are made of the past, hopes are part of the future, but only the present has value. Because with memory loss, the past is gone and the future, of course, is unknown. We don't know what the future holds. So trying to be mindfulness, present in the moment as much as you can, because those expectations, if they're not met, they leave us feeling disappointed.
Yeah, in your life. And I think a lot of people set goals and hopes in their life. Many times are unrealistic. So I used to work with patients about refocusing your hope, kind of refocusing to what your present situation looks like and helping them grieve that what's not going to happen.
Mm-hmm. Yeah, feel the feelings. Yeah. So there's a difference sort of with continuous grief versus grief after death. Grief after death is about us, those left behind. We adjust to what is lost, that physical person, their presence, their soul with us. Grief for a person with dementia is for the afflicted, so the person with dementia, as well as for ourselves, because we grieve for them as we see that they're unaware of the changes in their perceptions. We grieve that they don't often know what they have lost. And we grieve for the change in their relationship with us. So it's a twofold during this journey. And then grief after death allows us to move forward. We learn to hold them in our heart. We learn to make a new life built on, more memories that we experience after that person dies. But then grief for a person with dementia holds us in place in this space. So it prevents us from moving on and rebuilding. We're in it, we're in the midst of it. So we're not able to move on and forward. And every day we're reminded, just by being in their presence alone, what we've lost and what we're still losing and what we're continuing.
Yeah, I agree totally. It's just a different process.
Right.
And could last a very long time.
Right, because we don't know. Some it's 10 years from diagnosis to that. Some,
especially a lot of healthy people who have
right.
Alzheimer's, but the body is healthy. So
right, the mind fades first. So what kind of measures can we do to help foster acceptance and to help us come to terms with the reality? So for us to accept who the person has become, however they are, because we can't change it. Acceptance for what the person can do today. So being focused on that and not focus on what was lost, but what they're able to do today, and know that that can fluctuate. Accept that they're unable to consciously give us what we want from them as a spouse, as a child, as a sibling, as a friend. That's hard too.
Very. I was about to say, all of these sound so easy, but they're so very hard.
Yes.
Because it's refocusing your whole life of what you do.
Right.
What you experience with this person.
Exactly. And our life has changed forever. It's our new normal. It doesn't feel too good in that space because we know what we had.
Especially if you had a reciprocal relationship where you both give and take, and now you're the one giving and they're not able to give you much back.
Mm-hmm. Right, that shift.
Yeah.
But we can still give, and that's where that rewarding feeling comes, that hope comes from this, is giving to the person with dementia. We can give love to them. We can attend to them. We can be patient with them. We can ask for nothing, give, and just be open to whatever happens. So no expectations on the other person that they'll be able to pay us back, because they can't. We just give without strings.
Yeah, and that's why it's hard sometimes to talk somebody into taking a break or getting, even if they had to pay a sitter for a while or leave the house for a while. And I've had people offering that, and it's like, you need to accept the offer. I always found that people want to do something, they don't know what to do. So they'll say, call me if you need anything. But I've actually kind of pushed some caregivers. No, they want to do something, call them. You need to get out the house. If it's 2 hours, 3 hours, that kind of revitalizes yourself too, that you need that outside social contact. Yeah, or even a visitor in your home. I don't care if you rest in the bedroom or go sleep while they watch out for any needs that may happen. You need that, I think, a lot.
Right. And that comes to remember to give yourself the
Yeah.
same love, patience, and acceptance.
Yeah, I've had patients caregivers put off on the doctor appointments,
surgery.
and I'll never forget this one man taking care of his wife and did meticulous care, wonderful care. Missed his heart appointments. He had heart issues, missed like 2 of them. The aide walked in and found him, unfortunately, dead on the side of the bed of his wife. So sad, because then she ended up going to a nursing home because the kids could not care for her. And it was really sad to watch that because he was so in tune to taking care of her, he neglected himself. So I always try to take my caregivers, you need to take care of yourself.
Yeah, give permission to do that. You need it. So how is hospice different? We kind of talked a little bit about this. You know, we all sleep more, we all eat less as we approach death. Our bodies are designed that way. It's just how we work. But with dementia, those same behaviors may have no relation to the dying process. So it's not until eating becomes a big, big problem, when they can't chew, when they can't swallow, if there's choking involved, that we consider, you know, that's happening for that person with dementia. And then, of course, there's difficult decisions to make when a person is not consistently eating and kind of what to do next. And that's why advanced care planning documents are so important, to have those conversations often and early so that the burden is lifted away from the decision maker's shoulders. And then it shifts to honor that person's wishes, to know like, okay, I'm resolved. I know what they would want. It's what I'm doing. It's what I'm carrying out.
And that's a big thing, because I had a caregiver actually call me this week. Her mother is being taken care of by her stepfather, and she said he's doing excellent care, but her mother never wanted anybody to touch her finances because she had a first husband had kind of misused them, and never made any care plans or anything. And now she has dementia. It's getting to the stage of dementia where she's not always alert all the time. And she was saying, how can I get power of attorney? And I say, that's a legal question, because she might not be able to get that to you now. So she's stuck in a, place where I don't know what to do. I need help. We need to access my mother's to pay her bills, but it's just getting harder and harder. She realizes now how important that was.
Right. Yeah. Do your documents when you're healthy, before you get sick. That's the time to do it on the front end. But there's no right or wrong choices, just difficult ones, preferences. So, there's no right or wrong when it comes to planning, for your care. So ACHP-SW, I went to this sort of workshop recently. She talks about the positive physical approach for caring for someone with dementia. Getting into the person's visual range, and like she instructs like to put your hand up, palm up by your face, because when a person has dementia, like we wore these goggles. It was very, I recommend it. It was eye-opening. And so it was kind of trying to put you in the shoes of a person with dementia, but of course, we don't know how that is, but it helps to realize, oh, that's why, we do that thing. And then hand under hand and guiding them. And then on the edge of a personal space, like don't kind of go fast toward them. That may cause, like lashback. Right, exactly. So she talks a lot about that, and you can Google it, learn more, because it's really neat. So she says, if you come up from behind and touch, it creates the need to get away when we can't see them coming. That automatic flight or flight reaction, coming in too fast, touching or too smiley can be strange and confusing. So just kind of some tips to maybe think about when you're caring for someone, which you probably already know this, but this is helpful for like caregivers too, like paid caregivers. So here at the Hospice of Baton Rouge, where I am, our mission is to ensure our community has access to excellent, compassionate end-of-life care and grief support. And our vision is to educate and serve our community And we uphold compassion, community, and we strive for excellence and empathy. So who makes up the hospice team? And this is just in general, but that physician, nurses, social workers, CNAs, spiritual care providers, bereavement, sometimes speech, physical, or other occupational therapists are called in, volunteers, and each hospice has their own sort of extra programs. I can only speak for mine, but you know, we honor veterans. Pet Peace of Mind, that is when a person has a pet, they rehome them. I have a program for that. And then of course, Camp Conquer with the children who've experienced a loss. That's an awesome program. And then we have our upcoming grief center.
Yeah, which I'm excited about. And I can say it because I don't work here. But I think Baton Rouge, this area needs a grief center. We had one before, and it's going to be open to the public, to anybody. You don't have to be a hospice, have used hospice before, which is needed because it's hard to refer people to places that actually can get the support they need.
Yeah, so construction should be this month. So hopefully next year that'll be up and running. So looking forward to that. Just some things that are included in hospice, just for those of you who may not know what the benefit is about. It's extra things to help support you as a caregiver.
And I think that is important to know because a lot of people don't know. Talking to people who are in home health and then want hospice, I always tell them the difference is home health. There has to be a skill involved. The person has to be homebound, but also the nurse's focus is on curing, getting better, taking care of that wound or the skill, and then they leave. Hospice, because I'm having to explain why can't I keep the same home health nurse if they have a hospice, because the nurse's focus is different. The hospice nurse is trained to, I'm not going to cure this person, but I can keep them comfortable. I can keep them, meet their needs met, the nausea, the pain, keep that under control. And Medicare allows us to do more with hospice because you're not going to the hospital anymore. You're not going to any doctors anymore. So once you get into hospice, you don't do that aggressive treatment anymore. You want to stay home wherever your residence is and be taken care of at home.
Mm-hmm. So we talked a lot about that long goodbye and the journey and the lengthy progression, but when we're getting really close, so we're looking at about 1 to 3 weeks left of life prior to death from dementia, breathing often changes, and Barbara Corns talks about this, and then sleeping with your eyes partially open, restless. I see this a lot, the picking at the close, reaching up in the air, talking with the unseen. And then, of course, in the hours to minutes before, most people are non-responsive.
And have you found like a lot of patients I've worked with, there's this before, not really imminent right when they're dying, but maybe a week, a couple of weeks, 3 weeks before, it's like sometimes they'll stare off into space.
Or in the corner of the room.
Yeah, you know they're in another, and I always feel like my mother did that. I felt like she was processing her own death. Like,
or it's almost like 1 foot here and 1 foot there.
Yeah, I mean, I've had somebody who tell me they see people who have died before. I mean, my godmother was dying. We all ran to the house one night, and all of a sudden, when she woke up out of what was going on, she said, "Why are y'all all here?" And we said, "Well, we thought, you were going to go tonight." She goes, "Oh no, I'm not going." She named the exact date she's going to die because she said my mama, her mother, told her what day she was going to die, and she ended up dying on that day.
Yeah, we have so many stories. Yes, and that's why it's such a privilege that we are the ones to get to hear and experience, and it's just such an honor. It's to be there. At that time, we have so many stories. But as the end approaches, say your goodbyes, even though they can't respond to you, they don't have the energy to talk back, but hug them, love them, hold their hand, talk to them. Sometimes people take shifts, they need 10 minutes with them to say whatever is on their heart.
And I would always ask people if they want to do this, if they want to go in by themselves, or nobody, tell them, even if the person can't respond hearing, they can still hear you. So had a lot of families go in just by themselves because a lot of that's private, what they have to tell their loved one. At least they have a chance to do it.
And sometimes tied up in your sadness, you'll have this sense of relief, once your loved one has gone, and don't feel guilty about that, because there is, that where you can breathe sort of feeling, because you've been giving it your all, and you've been giving and giving and loving. And
when I was first told that, I got a little upset hearing that when somebody told me, because I had a sister-in-law who was very close friends with, and I did a lot of care for her. And I was like, what do you mean I should be relieved or happy because she's dead? She was 28 years old. But then I realized what they were trying to say as I got older. I realized, well, it is, because your time was taken up a lot, but also she wasn't suffering anymore. She's at peace. Just a lot of things go into that statement. So sometimes you're not ready to hear that at the time, but
just be gentle with yourself. No, you always did the best you could in an extremely difficult and demanding time, and just hold on to the good and gently let go of all else. Do we have any questions?
Thank y'all so much. That was a wonderful presentation. So helpful. And you really hit home, I think, on a lot of different topics y'all talked about. So anybody feel free to add your questions in the chat. I do have a couple of questions myself.
Sure.
One thing that kind of came to my mind when I was listening to you guys is something we work with a lot of families on, is it could be difficult for a family to accept a diagnosis of Alzheimer's. And then another factor in that is the difficulty when it's time to share it with your other family and friends as well. So I think you also hit maybe a challenge with that when it is time for hospice, and talking with other family members and friends that you've decided that hospice is a fit for your loved one. What would you recommend to a family that's maybe having trouble finding out, maybe they're on the page, they think hospice is a good fit, but maybe other people are having a hard time understanding that, or even maybe that caregiver is having a hard time, maybe there's some fear associated with the start of hospice. What would you recommend to somebody in that position?
I mean, we've always had family meetings. I've had countless.
With everybody involved.
Yeah, whoever's having problems processing and understanding, to hear it from the person in hospice sometimes is different if the main caregiver is struggling with the words to say or how to explain it, a lot of times, or even the nurse and myself would go and, that's part of kind of what we do. Yeah.
And being honest, I think Shelly and I both come from the philosophy, we don't push it.
Right. No,
because I've worked with a lot of people push it. We do not push hospice. We always say you need to be ready for it, but this is what it offers, and this is what it entails.
And you make the decision.
And I don't lie about it.
If it's a fit, you know.
Even saying like you're not supposed to go to the hospital anymore. Medicare looks at that. This is nothing aggressive. Just I try to be as honest as I can so they can ask their questions openly, and that's really helpful to a lot of people. When you get the ones that are against it together, offer yourself to go there.
Mm-hmm.
Thank you both. And Shelly, you saw the question about the references.
Yes, I just put my slide back. And thank you, Gina, for sending Tipa Snow's website there. I do have a references slide, but yes.
Gina's always on it.
Yeah, thank you.
There's no limit to how often. As a social worker, I have gone weekly.
Yeah, there's no limit to how many times.
I've gone daily to a patient. I had a 38-year-old with a heart issue, and I went daily because she lost 2 of her kids to foster care. There's no limit. You can go as often as you need to go.
Exactly. Yeah.
That's a great question.
Yeah.
Can y'all also go back? One slide I really liked was, can you go back and talk a little bit more about the whole hospice team and like everything that comes along with, because y'all are an amazing benefit to get to when you sign up, when you have hospice care, but can you talk a little bit about all the other professionals that also come along with that?
Yeah, definitely. The aide usually goes and gives the patient a bath, helps out. They're even able to get their own bath themselves. They just help with preparing the water and stuff.
For being there for safety.
Yeah. Chaplains, the spiritual care that they get, again, you depend the frequency with that caregiver, how often you want them to come. We're lucky because it'll be here, and in our agency, our chaplain does like a life review, where she does it with the patient, and then she types it all up and gives it to the family after they die. And that has been really appreciated a lot by the families who didn't even know some of the things the patient had lived through or went through. The social work, again, know about as often as you need them. We do supportive care resources, family meetings, or whatever's really needed. Again,
you're like the We Honor Veterans. A lot of our chaplains are veterans themselves, and they do the pinning ceremony to honor that person's service, military service. So,
and the doctor even makes home visits if they need to. The patient requests that. We can do that too. Does that help?
That's very helpful. Thank y'all. And another thing y'all mentioned as well, Shelly, I am also a Barbara Carnes fan. I have all of my books here.
Yes.
So I'm going to go ahead and link her in the follow-up email that I'm going to send out, because she does a really nice blog that she sends out weekly with different things that she writes, where she shares her opinion on really common questions I think a lot of families face. But I did want to, I wanted to just share that here at Alzheimer's Services, we have a resource library, and we have this book here that you guys referenced in your presentation a few times.
Wonderful.
And we have all of the other ones too. If anybody here is just wanting to ever borrow them, you can always do that. But we have a lot of these, which is the little blue book, The Gone From My Sight, talks about the experience of dying. We have a lot of them. So if anybody finds themselves going through this with their own loved one, we can always send you a copy. You can also find them on her site, on Amazon, things like that. But we have plenty here at our office, and she's a really good resource. So I will definitely link Barbara Carnes in the follow-up email, because I really like her myself too.
And it kind of relates to your other question about how can we help the family to other family members. Maybe it's picking up one of those books and say, here, read this, and then let's talk about it, you know, because sometimes hearing it from somebody else helps. And also sometimes reading it, you know, not everybody is an auditory learner. So like having it visually and writing maybe could help, you know, positive communication too.
Absolutely. You just never know what's going to work for somebody.
Yeah, exactly.
Awesome. Well, that is all the questions we have. I'm so appreciative to y'all. Thank y'all so much for this. This has really been a great presentation.
Thank you for the opportunity.
Yes.
Thank y'all. And I'm going to say, we have a lot of nice comments that have come in. I'm just going to save them for you guys, and I'll send them to you. So.
I'm sorry.
He's reading the chat.
And I also wanted to thank y'all too for sharing so much of your personal experience as well. That always is so relatable and really, really helps to connect the information. So thank y'all so much. We really appreciate it.
Thank you again, Ellen.
Thank y'all.
Appreciate it. Yes. Thanks everybody.
Thank y'all.
Appreciate
And
it.
thanks everyone for joining us. Everybody have a good rest of your day.
Thanks, you too.
Thanks.
Bye.